Thank you, Karim. Thank you, Giuseppe. And thank you, the e-sfar, for having invited me to give this talk. I took the liberty to change a little bit the title because we'll discuss the brain oxygenation that is comprising the brain circulation and the brain oxygen content. Here is my conflict of interest. So Giuseppe elegantly showed us that the controlling ICP is necessary, is very important, but it may not be enough. And as shown in this trial done in patients with high ICP, after the decompressive craniectomy, the ICP value were going down. But if we look at the 6 months outcome between the two groups, the group with decompressive craniectomy had a more unfavorable outcome than the control group. That means that controlling ICP is not a guarantee of a good outcome. And another paper was an observational study showing that a number of patients had a brain hypoxia as defined by brain tissue oxygen pressure lower than 15 millimeter mercuries, despite a normal ICP and a normal CPP. That means that could be due to silent brain hypoxia, and the silent brain hypoxia in this study was associated with a low number of patients with a good favorable outcome. So brain hypoxia is the imbalance between oxygen supply and oxygen consumption. In oxygen supply, you have a list of causes to reduce the delivery of oxygen to the brain tissue. Systemic causes like hypotension, low cardiac output, hypocapnia, hypoxemia, anemia, and local causes with the alteration in the gradient diffusion of oxygen across the brain tissue, microvascular collapse during the high ICP, microthrombosis, and vasospasm. And on the other hand, you have also situations with, where the oxygen consumption is increased as during cortical spreading depression, glucose dysregulation, and hyperthermia. Here is the picture of what we could have an alteration of a diffusion in oxygen across the brain tissue if we look at this capillary vessel and surrounding by a local perivascular edema that alter the diffusion of oxygen between the capillary and the astrocytes and neurons. At the end, the brain hypoxia is the independent factor of low outcome and a higher mortality, as shown in old studies showing that below 15 millimeter of mercury, the PbVO2 is associated with higher mortality. And the duration of this brain hypoxia is also a factor of higher mortality. And if we consider the outcome, the good outcome, this outcome is increased after adjusting for many factors, is increased when the PbVO2 is higher than 20 millimeter mercury. So in the ICU, how to measure the brain oxygenation? Please forget the use of near-infrared spectroscopy because this technique may function during the anesthetic environment, but in the ICU it is not a reliable technique. And because the most important issue is the contamination of the extra blood by the vessels around the vault. And in this study, when the head cuff was inflated in the front of face, we found a diminution in the nerve signal, meaning that the contamination was done by the extracoronal vessels. So we have the brain tissue oxygen pressure measurement. That is an invasive method to measure the oxygen pressure in the white matter. And this measure is affected or is influenced by many determinants that is very important to consider. The determinants related to the perfusion of the blood in the brain with cerebral blood flow, with mean arterial blood pressure, the CPP, and also with a variable related to the oxygenation, the oxygen extraction, the content in hemoglobin, and the oxygen and the dissolved oxygen. And in this example, the brain oxygen tissue is altered during a change in the PaO2, FeO2 range, and also is affected during the progressive anemia in ICU patient. But the most important parameters or equation to reflect the influence, the factor influencing the measure of PbO2 is done by this study during different challenges in hypoxia, in changing the arterial blood pressure, or during a hyperventilation challenge. And at the end, the most effective equation was the product of the CBF multiplied by the difference, the arterial venous difference in dissolved oxygen. So now is the consensus to consider that the PbO2 must be, if measured, must be maintained higher than 20 millimeters of mercury. And in cases of reduction in PbO2, we have to consider different causes, because by the low CBF, a low content in oxygen, a restriction in tissue diffusion, or a technical problem. PbO2 is also PbO2 raised some concern because it's a very local measurement in the brain tissue, despite a good correlation between global and regional CBF. And if we look at this study done to measure by the PET study the volume of ischemic brain volume in patients after severe TBI, we can see that there are no correlation between the volume of this ischemic brain and the value of PbO2. And more recently, during very large changes in ICP or in CPP or in the index of autoregulation, during this retrospective study, the authors found no clear relationship between these large changes with PbO2. So PbO2 probably does not reflect the global cerebral physiology in our patients. But this technique may help us to correct the brain hypoxia in the ICU. For example, to target, to individualize the best CPP in our patient. You know that each patient is not comparable to another one. And in this study, they found that the optimal CPP, meaning that this is the value where the autoregulation index, as reflected by the calculation of the PRX, is the best. They found that, for example, in this patient, the best CPP was around 60, And in this older patient, the best CPP was around the 90. So, and as a surrogate marker, they found that during this search for the best CPP, the PbBO2 was above 20 millimeter mercuries. So at the end, PbBO2 can help us to set the best CPP and not to choose the too high CPP that could result in vasogenic edema. PbBO2 can help us also to indicate the red blood cell transfusion in our anemic patient, because you know there is a gray zone between 7 to 9 gram per deciliter, and during this, in this gray zone where we don't know exactly how to manage the anemia, PbBO2 can reflect the consequence on the brain of the anemia and probably help us to decide not to transfuse or to give a transfusion for this patient. We have also other markers, the blood lactate or the supravena cava oxygen saturation. We have also to consider that it is not in the hands of PbBO2 to look at the hemodynamic conditions of our patient by looking at with echocardiography if the patient has a good cardiac function. And in this retrospective study, they found that in non-survivor patients after severe TBI, they all had a relatively lower index cardiac by comparison with the survivors. Hyperoxia is not the correct answer to correct the brain hypoxia, and was elegantly shown by Giuseppe and his team recently. And they look at a large range of PaO2 and FiO2 values in a large cohort of patients after TBI, and they found that with the increasing the oxygen delivery with hyperoxia only, we increase the probability to get a poor outcome. So PbBO2, despite some uncertainties, can be used to manage our patients in association with ICP. And in this paper and these recent guidelines, the authors imaging or defined 4 clinical scenarios according to the presence or not of intracranial pressure, high intracranial pressure, and according to normal or brain hypoxia. And in the first randomized trial, the author found that the information given by the PbBO2 in association with ICP, by comparison with no information, this added information was related to a lower time spent in brain hypoxia. So the question was, is this both or dual monitoring, ICP and PbBO2, was an help to guide the therapeutic strategy by comparison with only ICP therapeutic strategy guided with this monitoring in the reduction of the proportion of patients with poor outcome at 6 months. It was the OXITBI trial. I will present to you in some minutes, but it was also the same, exactly the same question addressed by 2 ongoing trials. The first is is conducted in the ICU in the USA, sorry, and the second is in Australia and New Zealand and some European countries. So we, based on the 4 scenarios I mentioned before, so we had the first group was ICP monitoring guided strategy, and in case of high ICP, we the team was were asked to initiate Type 2 and Type 3 treatments to maintain and to control the ICP. And in the ICP PBO2 dual monitoring guided strategy, we had 4 clinical situations. And in the case of brain hypoxia, if the brain hypoxia was associated with no high ICP, so we had to correct the brain hypoxia with the respect of some therapeutic interventions, looking at the correct the brain hypoxic hypoxia, and then to be sure that the patient was normally ventilated, had no therapeutic hypothermia, and a good CPP and a good cardiac index, and so on. And in the case of both brain hypoxia and high ICP, to look at first therapeutic to control the high ICP and then to correct brain hypoxia. So briefly, this paper is in press in the Lancet Neurology and probably published in the November issue of this journal. So we randomized across 25 tertiary French centers, the 2 populations, and you can see that the 2 populations were balanced in terms of the conditions of the admission at the emergency room, and in terms of severity, in terms of the classification of CT scan lesions. And on ICU, the 2 groups were also comparable. And with the implementation of the therapeutic algorithm in these 2 groups, we can see that teams had a very high compliance to the therapeutic algorithms, because you know that for most of time during the first 5 days of monitoring, so the ICP was grossly maintained into the normal range in the 2 groups, and also the same for the CPP. And in the PBBO2 groups, after initial period of time with brain hypoxia, the PBBO2 was maintained within normal range. So our primary outcome was the GOES results at 6 months, and we found no difference, no significant difference between the 2 groups. You can see here the proportion of patients with who died, and then these groups of patients with poor outcome, and very similar between the 2 groups. And if we look at secondary outcomes, goes 1 to 4 at 12 months, the disability rating scale, the functional independence measure, the intensity of therapeutic level, and the proportion of patients who were treated with type 3 therapies, the patients with critical events and mortality on day 28. We found no difference between the 2 groups after adjustment for the age and center. But we had the surprise to, in a post-hoc analysis, to find positive results between these 2 groups. If we looked at the patients who had initial on the first measure of ICP and admission, and the value being 20 and higher, we found that despite a very comparable variable between the two groups on admission, that at the end, at 6 and 12 months, the proportion of patients with low outcome were significantly reduced in the group of PBBO2. It's like the information given by the PBBO2 was not redundant with the ICP to manage the most severe patients from the first hours after the admission. So at the end, I would like to say that intracoronal hypertension is not exactly the same as brain hypoxia. Brain hypoxia can occur without intracoronal hypertension. And we have in our hands some intervention to change that may change the brain oxygenation. PBO2 is not a good reflection or a good measure to assess the global physiology of the brain after TBI, but this method can be useful to guide therapies against brain hypoxia and to have an impact on neurological outcome after TBI in the most severe patients. Thank you.